Hello everyone and welcome back to another lecture for the class MI224 Coding and Classification. I am Dr. Eve Raiza Catalbas, a first-year Master of Science in Health Informatics student from the UP Manila College of Medicine. Previously, I talked about HL7 or Health Level 7 International, and that lecture will be linked down below. For this lecture, I will be discussing about MedDRA or the Medical Dictionary for Regulatory Activities. MedDRA is short for Medical Dictionary for Regulatory Activities. It is a rich and highly specific standardized medical terminology developed to facilitate sharing of regulatory information internationally for medical products used by humans, both before and after a product has been authorized for sale. Products covered in the scope of MedDRA include pharmaceuticals, biologics, vaccines, and drug-device combination products. It was developed by the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use or ICH. Today, its growing use worldwide by regulatory authorities, pharmaceutical companies, clinical research organizations, and healthcare professionals allow better global protection of patient health. Here is a recap of how MedDRA came about. In 1990, there was still no standard medical terminology. So in 1993, the Working Party of the European Regulatory Activities and industry representatives reviewed and amended the UK terminology, then called MedDRA. In October 1994, the ICH adopted MedDRA version 1.0 as basis for international terminology. An ICH M1 expert working group was formed to further develop the terminology. In February of 1996, version 1.0 was released for alpha testing by pharmaceutical companies and regulatory activities. Then in July 1997, ICH agreed to the version 2.0 and renamed the terminology MedDRA, short for Medical Dictionary for Regulatory Activities. Later that year in November, the MedDRA Maintenance and Support Services Organization or MSSO was contracted to maintain and support MedDRA by IFPMA as a trustee of ICH. Now I'm going to discuss some of the milestones in the development of MedDRA. In August 1999, the MedDRA Desktop Browser, or MDB, was made available to users. In March 2005, the MSSO undertook the expansion of medication error hierarchy in version 8.0. The purpose of the hierarchy was to facilitate the goal of accurately capturing various types of medication errors and ultimately preventing them to improve the quality of public health care. 1 year later, free face-to-face training for new users became available to help them gain a better understanding of MedDRA. In June 2008, the web-based change request tool allowed users to submit change requests to MedDRA online. This provided the users the opportunity to request new and modify existing terms. Then in March 2009, the US FDA proposed a set of product quality terms for inclusion into MedDRA so they can use a single coding system for both adverse events and product quality issues. 2 months later, the Common Terminology Criteria for Adverse Events, or CTCAE, which was being used by the US National Cancer Institute to describe adverse events for clinical trials, was integrated with MedDRA. During the same year, in collaboration with the CIOMS WHO Working Group on Vaccine Pharmacovigilance, the MSSO reviewed the published definitions of 22 adverse events following vaccination as developed by the Brighton collaboration and proposed possible term additions to MedDRA to aid in vaccine pharmacovigilance. During the course of this review, the MSSO identified new vaccine-related terms that were implemented in MedDRA version 12.1. In January of the following year, the MedDRA web-based browser was made available to users. 2 months later, the European Medicines Agency proposed a set of microorganism terms to capture identification of an organism when there is no documented infection. Still within the same year, MedDRA was selected by the Alerting System for Chemical Health Threats project funded by the European Union Public Health Program for use in the Rapid Alert System for Chemical Incidents, or RASCHEM. One of the project goals is to incorporate a harmonized terminology of symptoms and syndromes to signal the possible release or exposure to toxic chemicals. Then, in July 2011, the enhanced WebCR tool was launched. The versioning tool was released in September 2012. This allowed MedDRA users to view the differences between any two versions of MedDRA. And finally, in July 2013, the new MedDRA website was released. What now is the significance and benefit of using MedDRA? The most important reason to code data into a standardized terminology is to analyze it. A key benefit of MedDRA is in its support of straightforward as well as sophisticated analysis. MedDRA can be used to analyze individual medical events or issues involving a system, organ, or etiology using its hierarchical structure. MedDRA can also be used for signal detection and monitoring of clinical syndromes whose symptoms encompass numerous systems or organs using its multi-axial hierarchy through the special feature of standardized MedDRA queries. We now go to the highlight of this presentation, which is coding with MedDRA. The MedDRA codes are composed of 8 digits, and each term is assigned a code. The codes are non-expressive and are initially assigned alphabetically by term starting with the sample code in this slide. New terms are assigned sequentially. The list of terminologies with their corresponding codes is updated twice yearly with each MedDRA release. It is also important to note that MedDRA is multilingual. The users of MedDRA have found it to be such an important tool that in addition to the English master, it has been translated into Chinese, Czech, Dutch, French, German, Hungarian, Italian, Japanese, Portuguese, and Spanish. Multiple languages allows most users to operate in their native language, which promotes accuracy and precision of assigning terms. This interoperability is very powerful and allows easy multinational sharing of data. Essential supporting documentation is maintained with each release of MedDRA in all the languages. Since all MedDRA terms are assigned a unique 8-digit numeric code, the code is assigned to the translated term in each MedDRA language. This allows for electronic submission of the same concept in any of the languages without loss of information or possible mistranslation by the sender or the receiver. The table on the bottom portion of the screen identifies the initial MedDRA version when each MedDRA language was made available to users. Next, we go to the MedDRA structure. First, we have the System Organ Class or SOC. It is the highest level of terminology and it represents an anatomical or physiological system, etiology, or purpose. Next, we have the High-Level Group Term or HLGT. It's a subordinate group for one or more of the HLTs. In the middle are the high-level terms or HLTs, followed by the preferred terms or PTs. Preferred terms represent a single medical concept. Finally, we have the lowest level of terminology or LLT. Each LLT is related to a single preferred term as a synonym or lexical variant. Here is an example of how MedDRA structure is applied. The SOC is a cardiac disorder. Subordinate to that would be cardiac arrhythmias. The HLT is rate and rhythm disorders, not elsewhere classified, with a subordinate PT of arrhythmia. Finally, the LLTs can be dysrhythmia, arrhythmia, and arrhythmia not otherwise specified. If you notice, the terms become more specified as you go down the structure. I highlighted in green other specified cardiac dysrhythmias because they are classified as non-current terms. Non-current terms are flagged at the LLT level within MedDRA. They are terms that are vague, ambiguous, outdated, truncated, or misspelled, or they may be terms derived from other terminologies that do not fit MedDRA rules. They are not recommended for continued use and are only retained within the terminology to preserve historical data for retrieval and analysis. Another feature of MedDRA is having multi-axial terminology. It means that medical concepts may be represented in multiple system organ classes. This allows for grouping by different classifications as well as retrieval and presentation via different datasets. To do this, the primary organ system will represent a PT during cumulative data outputs. The primary SOC will be used as well to support consistent data presentation for reporting to regulators. On your screen is an illustration of multi-axiality of MedDRA terminology. At the bottom, we have the preferred term influenza. Under the primary SOC, respiratory, thoracic, and multi-axial disorders, it will have respiratory tract infection and viral OT as its HLGT and HLT respectively. On the other hand, under the primary SOC infections and infestations, it will have viral infectious disorders and influenza viral infections as its HLGT and HLT respectively. Now we proceed to term selection guidelines for MedDRA. First, we have quality assurance. The premise is that the quality of original information impacts the quality of output. It is imperative for coders, therefore, to obtain clarification of data when necessary. Quality can also be optimized by careful design of data collection forms and proper training of staff. Second is non-alteration. Since MedDRA is a standardized terminology with a predefined term hierarchy, users must not make ad hoc structural alternations, including changing alterations or changing the primary SOC allocation. If terms are incorrectly placed, a change request must be submitted to the Maintenance and Support Services Organization or MSSO. As for LLT selection, it is important to note that the lowest level term should most accurately reflect the reported. When applicable, verbatim information should be selected. Next is term request. Company-specific workarounds for MedDRA deficiencies should be avoided. If a concept is not adequately represented in MedDRA, users are encouraged to submit a change request to the MSSO. The use of medical judgment is encouraged if the reports have no exact match to an existing term in MedDRA. Hierarchy checking, on the other hand, means that the user should check the hierarchy above a selected lowest level term to ensure that the placement accurately reflects the meaning of the reported term. Capturing reported information is one of the most important guidelines in MedDRA. Users are advised to select terms for every adverse reaction or event reported, regardless of causal association. Terms should likewise be selected for all device-related events, product quality issues, medication errors, medical histories, and social histories, investigations, and indications as appropriate. Another guideline is non-addition of information. In the example, it shows that the reported information for the patient were as follows: abdominal pain, increased serum amylase, and increased serum lipase. There are 3 different LLTs for each of the reported data for the patient, and the corresponding codes are reflected on your screens. Although the likely scenario is indeed pancreatitis, it would be inappropriate to choose pancreatitis as the LLT because it was not part of the reported data. There are 2 FDA-Defined coding errors, and they are missed concepts and soft coding. Missed concepts occur when not all reported information is coded. For example, the report states that the patient took drug X and subsequently developed alopecia, increased liver function tests, and pancreatitis. However, only alopecia and LFTs increased were coded. Pancreatitis is then considered as the missed concept. Examples of soft coding can be seen on the lower part of your screens. For instance, liver failure is only coded as hepatotoxicity and LFTs increased, or aplastic anemia is only coded as unspecified anemia. Another example is SJS coded as simply rash. In this part are further guidelines on how to select LLTs. When you are provided with either a single definitive or working diagnosis without accompanying signs and symptoms, they will be coded in the same way. The example shown is that of heart attack or myocardial infarction. However, if the diagnosis is accompanied by signs and symptoms, the rules for term selection changes. For example, a patient who suffered from rash, hypotension, and laryngospasm was formally diagnosed with anaphylactic reaction. In this case, only the definitive diagnosis needs to be coded or assigned an LLT. In contrast, a patient presenting with chest pain, dyspnea, and diaphoresis is currently being managed as a case of possible myocardial infarction. In this case, the symptoms as well as the diagnosis should be assigned an LLT. When dealing with conflicting or ambiguous information, here are some guidelines. For example, the report states that the patient presented with hyperkalemia with a serum potassium level of 1.6 mg per liter. Choosing the LLT serum potassium abnormal is incorrect since that will cover for both hyperkalemia and hypokalemia. Serum potassium increased would be a better choice for this case. Another example is a report stating that the patient presented with GU pain. Since GU may refer to either genitourinary or gastric ulcer, the better choice for LLT in this case is pain. When dealing with vague information, here are some guidelines on how to code them. For example, the report only reflects the phrase "turned green." Since this may refer to a patient or even a product, choosing the LLT unevaluable event is preferred. Another example is a report stating that the patient had an unclear medical problem. Since it is already known that the patient suffered from some type of medical error, the LLT ill-defined disorder may be chosen. Next, we go to coding medical information versus investigation results. For example, a patient presented with a blood sugar level of 40 mg per deciliter. If this was subsequently reported as hypoglycemia, its corresponding system organ class is metabolism and nutrition disorders. However, if this was reported as decreased glucose, it would link to the system organ class investigations. Diving further into investigation results, we have on the screen two examples of reports. In the first one, it was stated that the patient's glucose was 40 mg per deciliter. Since this is clearly below the reference range for glucose, it should be coded as glucose decreased. However, if the report only states glucose 40 without a corresponding unit, LLT of choice should be glucose abnormal since you are not sure whether that is 40 mg per deciliter or 40 millimoles per liter, however unlikely the latter option may be. Now that we have discussed a good number of guidelines, let's try to code the sample diagnosis. The first diagnosis is liver failure secondary to hepatitis B, liver cirrhosis. We can infer that liver cirrhosis is the underlying reason for liver failure and that liver cirrhosis was brought about by hepatitis B infection. The LLTs of choice would be liver failure, liver cirrhosis, and hepatitis B. Liver cirrhosis and hepatitis B were coded as separate LLTs because there is no one term to accurately represent Hep B liver cirrhosis. Let's move on to the next diagnosis, which is shock secondary to sepsis, secondary to possible spontaneous bacterial peritonitis versus bowel perforation. Septic shock was the LLT of choice for the first part of the diagnosis instead of coding sepsis and shock separately. This is because causality has been established and the LLT septic shock preserves the relationship between the two terms. On the other hand, the potential underlying causes are SBP and bowel perforation, and these are coded individually. Before we conclude this lecture, let's briefly discuss MedDRA licensing. It can be used either for free or at a fair cost, depending on the type of subscriber. Regulatory authorities, non-profit organizations, direct patient care providers, and educational institutions can subscribe to MedDRA for free. On the other hand, commercial companies and system developers have to pay an annual subscription fee. MedDRA has been and is being used locally, and an example of a company using this terminology is PPD. We likewise have license coders for this medical terminology here in the Philippines. And that is it for my lecture on MedDRA. On your screen are my references. Thank you for listening and watching this lecture. If you like this lecture, don't forget to hit the like button and subscribe to my channel for more lectures similar to this one. Again, this is Dr. MedDRA Catalbas, and thank you for your attention.